Respected teachers, I'll be starting with the background of today's JC presentation, Phase 3 trial of Cabozantinib to treat advanced neuroendocrine tumors. A little bit about NEDs. Neuroendocrine neoplasm arise from diffuse neuroendocrine cell system and may occur at many different disease sites. Most frequently, they occur in the digestive system followed by the lung. Neuroendocrine neoplasm encompasses of well-differentiated NETs and poorly differentiated neuroendocrine carcinomas. These NECs represent only 10 to 20% of the total neuroendocrine neoplasm. A little bit about the genetic aspect. The gastropancreatic endocrine tumors of the pancreas, duodenum, stomach, and less commonly the thymus and lung also may occur in association with MEN1 syndrome. Hereditary NETs, such as those linked with MEN1 or von Wipple-Lindau syndromes, account for 5% of cases. However, recent genomic studies have shown that 17% of apparently sporadic pancreatic NETs carry germline mutations, including those in DNA repair genes like MUTH, TYH, CHEK2, and BRCA2. The WHO classification of GEPNs is according to the grading, grade 1, 2, and 3. Well-differentiated NET grade 1 includes mitotic count of less than 2 per 2 mm square or Chi67 index of less than 3. In grade 2, we have mitotic count of 2 to 20 and Chi67 are of 3 to 20 range. In well-differentiated NET grade 3 or poorly differentiated NECs, the mitotic count is more than 20 and Chi67 index is more than 20. If we see the clinical classification of GP-NETs, around 50% of the intestinal NETs are 50% of GP-NETs are intestinal and 30% are that of pancreatic. Of them also with carcinoid syndrome, patient presented are 20% and without carcinoid syndrome around 80%. Same for the pancreatic NET, the non-functional part accounts for the major group of 70 to 90% and functional pancreatic NETs accounts for 10 to 30%. According to the site also, patients with pan-NETs or colorectal NETs have less favorable prognosis than patients with small intestinal NETs. Now, for the loco-regional or local disease, the treatment which is standard is the surgical aspect only. In the advanced setting, surgery is an option for managing metastatic GP-NETs, especially in stage 4 or patient with liver-dominant diseases. Curative resection of liver metastasis can lead to a 5-year survival rate of about 85%, though achieving this is often difficult. Palliative surgery may be used to prevent complications like bowel obstruction, especially in small intestinal NETs, while debulking surgery can help in alleviate the symptoms of carcinoid syndrome. Liver transplantation is considered for selected patients with unresectable liver mets, and loco-regional therapies such as RFA may serve as alternative to surgery. There are no data to support adjuvant therapy in NET grade 1 and 2. However, aggressive NENs, NEC grade 3, adjuvant therapy with platinum-based chemotherapy can be considered. Now, coming to a little bit about medical therapy options available. For symptom controls, the treatment options we know are somatostatin analogs, octreotide and lanreotide, which is the first-line therapy, grade 1A recommendation. Pasireotide is off-label for refractive carcinoid syndromes. Interferon alpha and telotrisat ethyl is also used for symptom controls. In case of progressive disease, we know we go ahead with PRRT. And refractive cases, we have options available of everolimus, diazoxide, and PPIs in case of Zollinger-Ellison and metastatic gastrinomas. Anti-proliferative measures include the treatment options of somatostatin analogs. In the case of metastatic slow-growing GP, grade 1 and grade 2 NET, we have data for use of octreotide. PROMET trial shows a treatment TTP of 14.3 months versus 6 months in placebo. Clarinet gave us a PFS of more than 27 months versus 18 months in case of placebo. Interferon alpha can, through various randomized trials, has shown to give a PFS of around 15.4 months. Everolimus in progressive pancreatic NET, GI NET, lung NET, grade 1 and grade 2 alone. Radiant trial has given us a data to provide around a PFS of 11 months versus 3.9 months in case of placebo. Other cases, in advanced unresectable pancreatic NETs, we have option of sunitinib. Now the available options for systemic chemotherapy. Systemic chemotherapy in general is effective only in case of pancreatic entities or NENs grade 3 of any site. Systemic chemotherapy indication for grade 1 or grade 2 well differentiated entities have no benefit as an adjuvant treatment also that we have discussed before, and it has a poor response. Other options available are STZ5FU, CAPTEM, cisplatin etoposide, temozolomide or capecitabine with bevacizumab, and temozolomide, CAP, PRRT, and other targeted options. Little bit about PRRT. It is indicated for progressive SSTR positive NET with homogeneous SSTR expression. Commonly used peptides are DOTA and DOTA-TOC. Preferred isotope, what we use now is 177 lutetium. And NETTER-1 trial showed, as compared to high-dose octreotide, gave a PFS of 28.4 months versus 8.5 months with high-dose octreotide. The ORR was about 18%. Versus 3% in high-dose octreotide. The toxicity with PRRT includes marrow toxicity. Around 3 to 4% may develop leukemia or dysplasia also, and mild renal toxicity grade 1 or 2 in around 30% of the cases. So overall, to summarize, the options available for grade 1 and grade 2 NETs in second line of progressive disease are PRRT, everolimus, sunitinib in case of pancreatic NETs, and in grade 3 NEC, we have cisplatin-based chemotherapy. The treatment of advanced neuroendocrine tumor is based on the factors such as tumor location, grade, hormone-related symptoms, and somatostatin receptor expression. Options for extrapancreatic NETs include somatostatin analog, lutetium 177 DOTA-TEC, and everolimus. For pancreatic NETs, sunitinib or alkylating chemotherapy may be used. However, most patients eventually experience disease progression. Angiogenesis is crucial in NET pathogenesis, and anti-angiogenic therapy targeting VEGF have shown effectiveness. Cabozantinib, an oral tyrokinase inhibitor targeting VEGF receptors MET, AXL, and RET, has demonstrated activity in treating NETs, which we'll be discussing further. Thank you.
Thank you, Shreya, for this background. Let's go to the methods and result part of the article. Dr. Sanjana, you can share the screen. Yes, the screen is visible. You can make it full screen and start.
Yes. Good morning, sir. Methods and material, which include study population, trial design, and endpoint. The study population is patients 18 years of age or older, histologically confirmed, locally advanced or metastatic, well or moderately differentiated neuroendocrine tumor.
You need to unshare and reshare again. I think it is not being shared correctly.
Okay. Is it visible, sir?
Yeah, now it's visible.
Okay.
Go ahead.
Neuroendocrine tumors of extrapancreatic and pancreatic origin, and WHO grades of 1 to 3.
On the center of the slide, then you will be able to change the slide.
Just sorry, sir. Also includes progressive disease according to the response evaluation criteria in solid tumors version 1.1 and Eastern Cooperative Oncology group of performance status score of 0 to 2, disease progression or an unacceptable side effect leading to discontinuation of first-line therapy. The design is a randomized double-blind phase 3 trial. It is a multi-central trial which began in July
Screen is not
2018.
visible. The slide which you're talking is not visible.
Oh, okay.
It seems that you have selected the incorrect window. So I think you have to stop share and reshare.
Sir, I will share it from my phone. Is it visible now, sir?
Yes, visible.
So the trial design includes extrapancreatic neuroendocrine tumor and pancreatic neuroendocrine tumor, which were randomized into Cabozantinib 60 mg daily versus placebo daily till progression. And the endpoints were primary endpoint. Primary endpoint was progression-free survival, and secondary endpoints were confirmed objective response, overall survival, and safety.
Go back to the previous slide. What was the inclusion population? It is not clear. Yes. So this was in the first line treatment, second line treatment.
Sir, it was after first line failure, disease
progression.
Yes, sir.
Or unacceptable toxicity leading to discontinuation of first line therapy.
Yes.
Okay.
So patient assessment, patients were evaluated every 12 weeks by means of radiographic imaging for tumor response and progression. A confirmed response was defined by 2 consecutive scans showing complete or partial response. The severity of adverse effects and the perceived attribution to cabozantinib or placebo were assessed by investigators using NCCN common terminology criteria for adverse events version 5.0. Statistical analysis. The statistical analysis for the trial was designed to ensure robust evaluation of efficacy of cabozantinib versus placebo. The sample size and power. The trial aimed for total 210 patients in the extra pancreatic neuroendocrine tumor cohort and 185 in pancreatic cohort. This design was intended to provide 90% of power to detect a true hazard ratio for disease progression or death of approximately 0.583 for extra pancreatic cohort, while 0.5 for pancreatic cohort. The primary endpoints were analyzed using stratified one-sided log rank test with an overall significance level at 0.025, and the analysis included 2 interim analyses for futile after 33 to 63% of projected numbers of progression events that had occurred. Hazard ratio. Statistical methods, which include hazard ratio, subgroup analysis, and intention to treat principle. Hazard ratio for the disease progression or death were estimated using stratified Cox regression model. The median progression-free survival and corresponding 95% confidence interval for each trial group were calculated using Kaplan-Meier method. Subgroup analysis were performed based on stratification factor and key demographic factor, including primary tumor site, grade, and previous treatment. These analyses utilized Cox model that included trial group assignment and interactions with demographic group. Efficacy analysis were concluded according to the intention to treat principle, ensuring that all randomized patients were included in the group to which they were designed, regardless of whether they completed the treatment. These statistical methods were crucial in determining the efficacy of cabozantinib in improving progression-free survival in patients with neuroendocrine tumor. Patient cohort, a total of 203 patients were randomly assigned to extrapancreatic neuroendocrine tumor cohort, and 95 patients were assigned to pancreatic cohort. The demographic characteristics of the patients were representative and generalizable to broader population of patients with neuroendocrine tumor. In pancreatic cohort, cabozantinib was associated with median PFS of 13.8 months as compared to 4.4 months for placebo. The cabozantinib group had 77% lower risk of disease progression or death compared to placebo group with a stratified hazard ratio of 0.223. In extrapancreatic cohort, the best response was stable disease, which was 87, while in pancreatic group, it was 39. Partial response was seen in 7, while in pancreatic, it was seen in 12. The median PFS in extrapancreatic group was 8.4 months versus 3.9 in placebo, while in extrapancreatic, it was 21.9 versus 19.7 in placebo. Overall survival also assessed although specific median survival times were not detailed in the provided expect. However, the results indicated a favorable trend to cabozantinib versus placebo. The safety population in the pancreatic neuroendocrine group cohort included 63 patients treated with cabozantinib and 31 with placebo. Notably, 68% of the patients in cabozantinib group experienced dose reduction, and there were grade 4 to 5 adverse events related to treatment. Overall health-related quality of life remained stable over time and was similar between the two groups who completed the questionnaire, indicating that the treatment did not adversely affect the quality of life. These results highlight the efficacy of cabozantinib in improving PFS in patients with pancreatic neuroendocrine tumor while maintaining a comparable quality of life. The most common adverse effect was seen is increase in AST in extrapancreatic group in cabozantinib cohort, while in pancreatic cohort, the most common toxicity was fatigue, while the most common cause for withholding cabozantinib was hypertension, which was seen in 28% in extrapancreatic and 14% in pancreatic. The incidence of adverse effect attributed to cabozantinib was 98% and to placebo was 84%, with incidence of grade 3 or 4 treatment-related toxicity of 65% in cabozantinib and 23% in placebo. The most common treatment-related side effect was hypertension in 22%, fatigue in 11%, and thromboembolic events in 11%. No grade 5 events were noted in pancreatic neuroendocrine tumor cohort. Thanks.
Thank you. Vartika, you can go ahead. The discussion.
Yes, sir. Yes. Hmm? Am I audible, sir?
Yes, yes, please go ahead.
Yes. So I will be discussing on the cabinet phase 3 trial. So we'll be discussing that how the landscape of neuroendocrine tumor has evolved over a time. So the therapies which are first line are based on the following landmark trials. So this is a NETA-1 trial, which was a phase 3 trial of 177. 177. Am I audible, sir?
You are audible.
Yes. So, NETA-1 trial was a phase 3 trial of 177 lutetium-DOTATE for midgut neuroendocrine tumors, which the study's primary endpoint was progression-free survival, and it revealed that in the lutetium-DOTATE group, median PFS was not reached, whereas in the octreotide-only group, it was 8.4 months. Rate of progression-free survival at 20 months in lutetium-DOTATE group, it was 65.2%, and in control arm, it was 10.8%. Next, TKI for which we have established data is sunitinib, which is approved, which can be considered as another first line for metastatic neuroendocrine tumors. So this was a trial for sunitinib for metastatic progressive pheochromocytomas and paragangliomas. It was a first landmark trial of sunitinib, first map, an academic multicenter international randomized placebo-controlled double-blind phase 2 trial, which revealed that median PFS was 8.9 months in the sunitinib arm, whereas it was only 3.6 months in the placebo arm. Another therapy which have been evaluated were Radiant 4 trial. It was international double-blind placebo-controlled phase 3 trial, which included 302 patients and included progressive non-functional lung or gastrointestinal neuroendocrine tumors. It compared everolimus versus placebo. In this, median PFS was 11 months versus 3.9 months in placebo group. Hazard ratio for progression or death was 0.48, and it was statistically significant. Objective response rate of 2% was seen for everolimus versus 1% for placebo. So how did we came from sunitinib to cabozantinib? So evidence of cabozantinib role in neuroendocrine tumor came from this preclinical study, where the study was suppression of tumor invasion in METs by concurrent inhibition of c-MET and VEGF signaling in pancreatic neuroendocrine tumors was studied. The results showed that simultaneous inhibition of c-MET and VEGF signaling not only slows tumor growth but also reduces invasion and metastasis. Following which, further other trials were conducted for cabozantinib. So there was another phase 2 trial of cabozantinib in patients with carcinoid and pancreatic neuroendocrine tumors. The results of which showed that treatment with cabozantinib was associated with objective tumor response and encouraging PFS duration. Median PFS that was observed was 21.8 months in pancreatic neuroendocrine tumors, whereas median PFS was 31.4 months in carcinoids. Another trial based on the cabozantinib was cabozantinib in patients with unresectable and progressive metastatic pheochromocytoma or paraganglioma, which is the NETALI trial, a single-arm phase 2 trial, which revealed that overall response rate with cabozantinib was 25%, clinical benefit rate was 94%, and median PFS was 16.6 months, which is much more than sunitinib. And also, what this trial concluded that responses to cabozantinib are independent of the genotype. Both patients with the succinate dehydrogenase B pathogenic variant and patients with apparently sporadic metastatic parasympathetic paraganglioma responded well to therapy. Talking about the cabinet phase 3 trials, which evaluated cabozantinib in advanced neuroendocrine tumors. So as we have seen that this trial revealed that median primary endpoint of this trial was median PFS, which was 13.3% in 13.8 months in cabozantinib group as compared to 4.4 months in placebo group. Whereas there was no statistical significant difference in overall survival. And also this trial had a subgroup analysis for progression-free survival in pancreatic neuroendocrine cohort. So as we can see, based on the age, sex, race, ECOG performance of 0 to 2, previous use of somatostatin analog, TKI therapies, or use of everolimus and PRRT therapy, all favored the trend towards the use of cabozantinib. Whereas the tumor grade, it was poorly differentiated, or the histology was unknown, where there it was like a mixed response. So safety and exposure aspects of cabinet trial. So what we saw that dose reduction, as we were comparing both pancreatic neuroendocrine tumor and extrapancreatic neuroendocrine tumors. So dose reduction was required in 60% of cabozantinib in extrapancreatic as well as 68% in pancreatic neuroendocrine tumor group. Patient had to stop cabozantinib due to adverse events in 31% as well as 21% in extrapancreatic and pancreatic neuroendocrine tumors respectively. Incidence of adverse event was more in cabozantinib group in both the subgroup of tumors, and grade 3 or higher treatment related events were seen in cabozantinib group as compared to placebo of 62 and 65% respectively. Whereas grade 5 events were seen in extrapancreatic neuroendocrine tumors, which was 7%, which included gastric hemorrhage, cardiac arrest, and one cause was unknown. Whereas there was no grade 5 events in the pancreatic neuroendocrine tumor group. So most common treatment-related grade 3 or 4 adverse events which were noted in extrapancreatic neuroendocrine tumor group was hypertension, which was seen in 21%, fatigue in 13%, and diarrhea seen in 11%. There is the most common treatment-related grade 3 or 4 adverse events in pancreatic neuroendocrine tumor was hypertension in 22%, fatigue and thromboembolic events in 11%. So SWOT analysis of cabinet 3 trials. So strength of this was that cabozantinib as a new treatment option for neuroendocrine tumors. So there is a strong preclinical evidence for cabozantinib. It has robust preclinical evidence which supports its potential success in clinical trials. Efficacy in progression-free survival. It had a median PFS of 8.4 months for extrapancreatic and 13.8 months for pancreatic neuroendocrine tumors. Adverse events observed in this trial were consistent with the known safety profile of cabozantinib. And consistent results were seen across the subgroups of pancreatic and extrapancreatic groups. Trial included patients with various background, previous treatment, and tumor types. The consistent improvement in progression-free survival across subgroups strengthens the reliability of cabozantinib's efficacy. Since the result was PFS was statistically significant, so it concludes that showing the improvements with cabozantinib were not due to chance. And it has a potential for filling a treatment gap for patients whose disease has progressed after other treatment. Cabozantinib offers a new therapeutic option addressing an unmet need in this population. Weakness of this trial was that there was early termination of the trial on the basis of interim analysis. Results could potentially lead to overestimation of treatment effect. Overall survival being affected by crossover and subsequent anti-cancer therapies. Placebo was used in place of active comparator. Could be a reason that there is still a lack of established alternative on progression. High incidence of adverse events was seen. A significant proportion of patients experienced grade 3 or higher adverse events, including hypertension, fatigue, diarrhea, limiting patient tolerance and adherence to therapy. what opportunities we have for future, that now we are coming with combination therapy. There is a potential to study cabozantinib in combination with other treatments such as immunotherapies or other targeted therapies, which could enhance its effectiveness or mitigate adverse effects. Addressing the unmet needs, the treatment landscape for neuroendocrine tumor is limited, especially after disease progression following first-line therapies. So, and also expansion to other indication. Given its mechanism of action as multi-kinase inhibitor, cabozantinib has potential to be explored for other type of cancers. In patients with genetic testing showing no mutations, cabozantinib could become a first-line option as well. Role of immunotherapy, for which various trials are being conducted, which is Keynote 028 trial for pembrolizumab as monotherapy, being evaluated in neuroendocrine tumors, which revealed an overall response rate of 12%. Keynote 158 is another trial for pembrolizumab monotherapy in advanced well-differentiated neuroendocrine tumors, which revealed an overall response rate of 3.7%. AVENEC trial for evolumab monotherapy in advanced grade 3 neuroendocrine tumors, which revealed an overall response rate of 6.9%. And another trial for spartalizumab as monotherapy is going on, which revealed an overall response rate of 7.4% and 4.8%. What is upcoming is another opportunity for neuroendocrine tumors is a phase 2 trial of atezolizumab and bevacizumab in patients a phase 2 trial of atezolizumab. Am I audible, sir?
But the screen is changed.
Sorry, sir. Just a second.
You have zoomed the screen, I think.
Is it now visible, ma'am?
Yeah.
Yeah. So another opportunity is a phase 2 trial of atezolizumab and bevacizumab in patients with advanced progressive neuroendocrine tumors, where results revealed an objective response rate of 15% in extrapancreatic neuroendocrine tumors and ORR of 20% in pancreatic neuroendocrine tumors, whereas median PFS was 14.9 months in extrapancreatic neuroendocrine tumors and 19.6 months in pancreatic neuroendocrine tumor. So this combination is also showing a moderate clinical activity in neuroendocrine tumors. Further studies are needed to evaluate this combination. Other TKIs are also being evaluated. For example, pazopanib in pre-treated advanced neuroendocrine tumors. It is a phase 2 open-label trial of the Spanish task force group for neuroendocrine tumors, which revealed a median PFS of 9.5 months. Other results which were observed in this trial that 25 patients were progression-free at 6 months. Clinical benefit rate at 6 months was seen in 73.3% in prior TKIs. If patient has received prior TKI treatment. 66.7% clinical benefit rate was seen without any previous therapy. 60% clinical benefit rate was seen in patients received mTOR inhibitor, and lowest rate of 25% was seen in patients who received it after TKI and mTOR inhibitors. Overall, this trial concluded that median PFS of 9.5 months was seen with pazopanib. Further trials are required to evaluate the efficacy of pazopanib. What are the threats in this trial? That there is an immature overall survival data. Need to consider the TK resistance and competition from established therapies. Need to demonstrate either superior efficacy or a better safety profile to compete effectively with sunitinib or temozolomide or other first-line therapies like octreotide, which we are using currently. So conclusion is that progression-free survival benefit was observed within both the extrapancreatic and pancreatic NET. There was no overall survival benefit. Overall response rate in extrapancreatic neuroendocrine tumor was 4% as compared to 1% with the placebo. Whereas in pancreatic neuroendocrine tumor, it was 18% with cabozantinib versus 6% with placebo. And there were no new safety signals were reported. Thank you.
Thank you, Vartika. So can you tell what was the percentage of crossover in this study? Because the PFS is very significantly different, but OS is not different. So what may be the reasons for this non-significant OS?
So there was a crossover.
Yes. So what is the crossover percentage? How many patients receives cabozantinib on progression in the placebo arm? So that becomes important, no? Otherwise,
Yes, sir.
otherwise, how will you understand the benefit of the treatment?
Oh, yes, sir.
And was there any quality of life analysis in this study?
I didn't mention, sir. Just,
Quality of life was not mentioned.
yes.
So these are some of the points which are important actually. So you can see a very significant PFS difference, but you are not observing OS difference. So you need to understand what might be the OS reasons for not showing overall survival difference. So in such trials, most of the time the most important point is the crossover, because whenever the patient is progressing on the placebo arm or observation arm, they will receive that treatment. That is here in this trial, it was cabozantinib. So what will happen? The survival difference in overall survival will be dampened. So that
Yes,
is for the treatment perspective, it is good only, but for the trial perspective, it's not so good. But when we see the ethical concerns, we always want to give crossover treatment to our patients so that the patient receive the benefit of the treatment at least in the next line, if not before, because there are extremely limited options in this setting. Even selecting placebo as a control arm, so that was also being questioned. But if you see the ESMO recommendation, there is no clear-cut guideline to utilize the second-line treatment, especially in extra pancreatic NET. In pancreatic NET, at least there are some options. We know that everolimus is a standard option post-progression octreotide, but in extra pancreatic NET, there are limited options, and there are no significant studies actually, large studies to establish the benefit of the second-line treatment. So that is why it was chosen as a placebo as a control arm. But in pancreatic NET, I will be somewhat cautious because placebo is not the standard of care in the second line treatment, as per the ESMO as well. So and during the presentation, an ESMO chart was being shown. You can show it. You can stop the screen sharing so that we can come to that ESMO chart of the treatment options. You can stop the screen sharing directly. This one. So this is the ESMO recommendation. It is somewhat difficult and confusing, but what we see, it can be summarized based on this. So you need to divide it into first NET and NEC, and it should be understood that after 2018 WHO classification, NETs are also grade 1 to grade 3. Previously, all grade 3 tumors were considered and treated as NEC, but that has changed now. So NEC is completely different from NET now. And NEC which is usually grade 3 with chemotherapy, platinum-based chemotherapy, and first-line treatment is usually cis or carbo with etoposide. Second-line treatment options include FOLFIRI or CAPTEM. We utilize CAPTEM most of the time. but other options include utilization of FOLFIRI. FOLFOX usually not utilized because platinum is already exhausted. So, and again, utilizing a platinum-based treatment might not be so useful. So the preferred option which we utilize is cis-itopo followed by Captem. That is the protocol for NEC. And sometimes we also utilize irinotecan-based treatment. Either irinotecan single agent or FOLFIRI regimen can be utilized. So this is about NEC. Now coming to the NET per se, you can see it is the data is for small intestinal NET and pancreatic NET. And most of the trials are for pancreatic NET. Now there are trials for extra pancreatic NET as well. But most of the time, pancreatic NET, which are much more common, that is why there is much more data for pancreatic NET. And even the trials which included extra pancreatic NET, the extra pancreatic component was actually smaller in all the trials. That is why all the data is primarily for pancreatic NET, with some patients included for extra pancreatic NET. So if you see the recommendations, grade 1 NET, stable disease or slow growth, this the Ki67 is below 10%. There is an option to utilize somatostatin analogs, which we utilize long-acting octreotide, that is somatostatin analogs. And the on progression with first-line somatostatin analogs, that is long-acting octreotide, there is an option to utilize Captem, everolimus, sunitinib, apart from chemotherapy agents, which is not very commonly utilized. So Captem, everolimus, sunitinib, all three are acceptable options. And in the third line, PRRT is an option. This is for pancreatic NET, grade 1 tumors. Grade 2 tumors, which we see more commonly, grade 1, grade 3, both are less patients. In this trial also, grade 2 are the maximum number of patients. So grade 2 NET, pancreatic NET is one of the most common scenario which we encounter in the clinical practice. So first line treatment option you see here for grade 2, they have mentioned to be directly Captem, everolimus, sunitinib. It is not somatostatin analog. That is another point which should be highlighted here for Ki67 less than 10%, but grade 2 tumor, that is Ki67 between 3 to 10 for this case. And the second line treatment option will include PRRT. If we see the grade 3 NET, pancreatic NET with Ki67 between 10 to 50%, Captem is the first line treatment option which you utilize. And the second line is everolimus and sunitinib, and third line is PRRT. So you can see PRRT is presently being recognized in the guideline settings as third line or second line treatment options, though the NETTER-1 trial is available and it is challenging this paradigm. And this needs to be carefully discussed in the multidisciplinary team discussions. And it is highly based on the avidity of the tumor and expression of the somatostatin receptor. This is SSTR expression on the DOTA PET becomes really important to select the patients. Also, the location of the tumor, which is important. Coming to the extra pancreatic NET, that is primarily small intestine NET. One option is watch and wait. And if the tumor is SSTR positive, Ki67 is less than 10%, and the slow growth is documented. Patient has progressed on watch and wait scenario, or the patient has progressed now. There is option of utilizing somatostatin analog. So here, somatostatin analogs are the prime treatment, and here you can add loco-regional therapy as well. The reason for adding loco-regional therapy here for selected patients, for example, primarily liver burden disease, is that these patients have poor responses to all the TKIs and other treatment options. Here in this study also, we saw that the patients are not responding well to even cabozantinib in the second line setting in extra pancreatic NET, and the prime benefit, the maximum benefit is in the pancreatic NET. So if you can control the disease loco-regionally and the disease is limited apart from a small intestine, there's an option to use loco-regional therapy, which includes various treatment options like RFA and portal vein embolization. These are the options. Then in the second line PRRT, and third line is the everolimus. So this is the sequence of treatment in small intestine grade 1, grade 2 NET with Ki67 below 10%. But between 10 to 15%, between 10 to 50%, actually, everolimus is the first line treatment option in grade 2 extra pancreatic NET, followed by PRRT. SSTR negative, PRRT will not be option, so the sequence will become separate. But again, you need to understand the somatostatin analogs do not work well even when the SSTR expression is 0. So you can see when the SSTR expression is negative, so utilizing octreotide is not a treatment option. So you will utilize PRRT as well as octreotide when there is SSTR expression. Then only there is a benefit of utilizing octreotide. Some patients do not have octreotide SSTR expression, then you can directly utilize everolimus or treatment with other agents. Now cabozantinib is an option. So these are the points which needs to be understood. So this is a complex algorithm. This is so complex because it is based on the various data sets which are available. It is not directly the treatment perspective, but it is due to the data set which is available for the particular settings. But the key take home is that if SSTR is negative, you can directly go ahead for pancreatic NET with CAPTEM based protocols or everolimus or sunitinib. And in small intestinal NET, you can directly go with either locoregional therapy or everolimus based on the feasibility of locoregional therapy. At the same time, if the patient is progressing on the first line treatment algorithm, PRRT is one of the important options, which is a standard of care presently in the second line settings in all the both pancreatic and extra pancreatic, but SSTR expression should be there. And in the grade 1 tumors, you can see somatostatin analogs are well established. In grade 2, somatostatin analogs are not there in any of the guidelines actually. So this is a slight difference which we practice very commonly, because even in grade 2 NET, we sometimes utilize somatostatin analogs. But as per the data sets which are available, and if patient is having Ki67 more than 10%, there's very limited role of octreotide analogs. This needs to be taken into account. And with the data of cabinet trial, cabozantinib is an established treatment option in the second line setting. So this is a slightly difficult topic, and multiple conflicting data sets and data sets are available which are not directly corroborating with each other. So I will request comments from Vanita ma'am. She suggested us to go and discuss this article, which is a very useful article actually.
Thanks, Akhil. No, this was your overview of the treatment choices was excellent, very helpful. So just a couple of comments about the study. I am surprised that it was a placebo-controlled study in this day and age in the second line setting. So I'm not sure that in the clinic, if we see a patient with progressive NET who has received either a somatostatin analog alone or everolimus, we on the second line setting, we would not offer therapy. So I don't really know how to apply this data. I mean, we know that VEGF inhibitors do have activity. I think we know that this from other earlier data sets, phase 2 studies. But I'm not sure where to place cabozantinib currently in the treatment algorithm. Should we place it in the second line setting? Is it more effective than the other available therapies? Is it more effective than perhaps everolimus or sunitinib or So I'm not quite sure. What is your take on this, Akhil?
Yes, ma'am, completely agree. As I discussed, ma'am, extra pancreatic definitely treatment options are limited, but in pancreatic there are at least 2 to 3 lines treatment options are already there. So definitely placebo is not a standard of care option in pancreatic NET. And even if we see the extra pancreatic NET, we can see up to 3rd line treatment options given in the ESMO guidelines itself. So I completely agree, ma'am. So what we do presently is to utilize cabozantinib when first 2 lines or 3 lines, the standard treatment options are exhausted. Patient is not feasible for PRRT. In those situations, we utilize cabozantinib.
Perfect. And the only other comment I had was I was listening with interest to your discussion about overall survival. And absolutely crossover is important. But I think in a trial like this, with some of the tumors maybe relatively slow growing, one of the reasons why you may not be able to see a survival benefit, particularly when you first report the trial, is that the events have not occurred. I was not able to find how many events had occurred in the study. I only skimmed through it, so maybe they have mentioned it, but that may be one of the reasons. So if events haven't occurred at all, or less than the number of events that they had planned for, then you would never be able to see a survival difference. So I think that was my only other comment.
Okay. Okay, yeah, that means follow-up duration becomes important, and how many events had occurred in that follow-up duration.
Yeah.
Yes, ma'am. Thank
But
you.
I
Thank you.
think this has made us a bit more confused than cleared up. It's given us another option, that's for sure. It also teaches us that even in this day and age, you can do a placebo-controlled trial. I mean, and this is a multi-centric, multi-country study, was it?
Yes.
No,
yes.
Alliance. I think US only, no? Maybe. I'm not sure. But either way, it was definitely multi-centric. So this was approved by multiple ethics committees. I'm not really sure that it would have been approved by us. I think that may be something for us to, food for thought, that this is considered completely appropriate by a lot of people. So that's something to think about and chew on.
Yes, ma'am. Thank you, ma'am. Thank you. Any other comments or questions by any residents? Because this is a confusing topic, not very easy to understand and digest. We recently had a discussion about this, the treatment of NETs in our Varanasi lectures. That is why we had some idea, but it is actually a very difficult topic and not so enough data. Any questions or queries? If not, I will request either Kumar sir to give some comments. Or
And I
yes,
agree
sir.
with you. All the comments, and it was nice discussion and useful data in the clinic, because we know that this drug we can use it tomorrow.
Yes.
I
Thank
didn't realize you were here, Dr. Kumar. Your comments on the fact that it was a placebo-controlled study in the second line setting?
So I heard that. I heard that discussion. Fair comment. So I agree with you. When in second line also treatments are not so effective, placebo control trial is a fair choice, and I totally agree with your comments. Good that we have, so that people do know that treatment. What is the benefit? What is the real benefit of that treatment being available? So as much it should be criticized for being placebo controlled, it should also be
Commended.
yes, commended that they thought about it, that this is the way this drug can be taken forward. And I agree, there are 5-6 options in the first line setting, and what it means that you can use it sequentially the way we have done for many other tumors if you take NCCN. And good that someone had the courage to put evidence in this setting.
Thank you, sir. Mishra sir, for your final comments.
So I think it is we can at least in a second line setting, we are getting 13 months PFS. It is not very bad, such a rare disease, and where the chances of doing studies are not very easy for this setup. Definitely, we have one more option, and we can utilize in our patient for the benefit of the patients.
Thank you, sir. So if there are no other further comments, we can end now. Thank you, everyone.